My name is Steve Vieweg. I'm the Associate Director of the Center, and it is my great pleasure to host this year's Campus Keynote Address. The IUPUI Center for Translating Research into Practice was founded by Dr. Sandra Petronio, Professor of Communication Studies, who's an achieved translational scholar and the Director of the Center for Privacy Management. Her work in privacy management is particularly pertinent these days as we navigate the increased use of virtual technologies. When Dr. Petronio and Chancellor Emeritus Charles Bantz first came to IUPUI, they recognized our campus was the most translational they had ever experienced. They also noticed that we're a pretty modest campus that doesn't always boast our good works. So that began Dr. Petronio's quest to recognize and appreciate the many unique examples of research that seek to address questions and challenges that solve problems that people face in their everyday lives by using meaningful, evidence-based information to address the complex social, health, governmental, cultural, and relational issues we face in our communities. IUPUI is well known as an integral partner with our Indianapolis and our Indiana community. And right now, during a pandemic, is no exception to the value of those partnerships. There's so much to explore and to understand as we engage our amazing students, staff, faculty, and community partners in translational research that makes the world a better place. While Chancellor, Dr. Bantz encouraged the celebration and expansion of translational work as part of the fabric of our campus. As Executive Director of the Center now, he continues to promote this work through a variety of programs, including today's keynote address. Now, speaking of technology, we're taking advantage of Zoom to make this keynote address available to our campus and our community. You might have noticed in our pre-show information that we're recording today's session for those who are unable to join. And we will ask you to stay muted and turn your camera off during the presentation. And we'll invite your questions and comments at the end during the dialogue portion. You're encouraged to share your questions in the chat, or we can simply invite you to unmute later. But for now, hold on to your questions and just share them in the chat as they come along. So to take advantage of our limited time, it is my great pleasure to introduce our keynote speaker, Dean Bernadette Melnyk from the Ohio State University School of Nursing. Dr. Melnyk is recognized nationally and globally for both her clinical knowledge and her innovative practices and approaches to a wide range of healthcare challenges. Her groundbreaking work spans evidence-based practice, intervention research, child and adolescent mental health, and health and wellness. Throughout her impressive career, she's received many accolades and awards, but we are most anxious to invite her here today to share her translational research around the important and timely topic of healthcare with our campus community today. So please help me welcome Dean Melnyk to share her presentation, Narrowing the Research Practice Time Gap to Improve Population Health and Well-being Outcomes, Evidence-Based Translation Strategies That Work. Welcome, Dean Melnyk.
We will sail through this very well. So Steve, can you tell me if you can see the slides?
Yes, the slide is there and we hear you clearly. So you've achieved your goal.
Fabulous. Well, I want to start off by asking, how many of you are excited about narrowing this research practice time gap? Even if you're not excited, I'd ask you to act excited for us. I'm really enthusiastic to be here with all of you today to talk about the model that I have used that has worked so successfully, but also to share what I believe are some very key factors in this translation work. I just want to disclose a conflict of interest. I have a company called Cope to Thrive that disseminates my research-based COPE programs. I want to start with a personal story because it has applicability for my presentation today. I grew up in a small little coal mining town in southwestern Pennsylvania, right on the West Virginia border. My dad was a coal miner. We lived in a half of a little house. I'm sure we were labeled working poor, but I was born with resiliency, and I still can make lemonade out of lemons any day. And that resiliency came in handy on a cold January day when I was 15 years of age, home alone with my mom. We had a great time during breakfast, chatting and talking. All of a sudden, she sneezed, stroked out, and died right in front of me. Well, you can imagine how traumatic that was for a 15-year-old teenager. I suffered from terrible post-traumatic stress disorder, depression, anxiety for a few years after she died. After a few months of nightmares, not sleeping, not eating, not functioning well in school, I was taken to my family physician for help. There was no mental health counseling in my little rural town of Republic, Pennsylvania. Well, that physician did what so many providers still do today in 2021. Got out the prescription pad, wrote a script for Valium, and said, give Bern one of these every night. She'll sleep and be just fine. Well, I remember taking a Valium that night. I slept for the first time in months, but I woke up groggy and I said, I don't like this feeling. I don't want to take these. I just got to gut it up and cope. But in the next 4 years, I also lost a cousin who was like a brother to me after a car accident. I lost the only grandparent I ever knew and loved. And when I was 19, my dad had his massive heart attack. Those events, all that grief, you know the story. What doesn't break us only makes us stronger. And as a result of what I went through as a teenager, I became passionate to become a nurse, then a pediatric nurse practitioner, and a psychiatric nurse practitioner, and go on to get my PhD so I could develop evidence-based interventions to improve mental health in children, teens, and college students. Well, the other sad part of that story is my mom had a history of headaches for over a year. And my dad kept saying, go to the doctor, figure out what's wrong. She went to our family physician just 1 week before she died. Her diagnosis, high blood pressure, given a prescription for a blood pressure medication that my dad found in her purse after she died. I think you now can understand why I had a big dream to go to a big public university and be their first chief wellness officer. So I left sunny Arizona 9 years ago to come to Columbus, Ohio. And I will tell you, I was so blessed for Gordon Gee being our president at that time, because I pitched that dream to Gordon, because there was not one university in the country who had a chief wellness officer. Lots of corporations had CWOs, but not universities. Gordon listened, I mapped out a plan, and he gave me resources to spearhead population health and well-being at Ohio State. I have long had a philosophy: in God we trust, but everybody else better bring data to the table. I still live by that philosophy, and we use it at Ohio State. We really take a population health, evidence-based quality improvement approach to health and well-being for our faculty, staff, and students. Well, every hospital and healthcare system throughout the country is trying to reach the quadruple aim in healthcare. Years ago, the Institute for Healthcare Improvement said, we need to strive to reach the triple aim. That includes enhancing the patient experience, improving population health, and decreasing costs. And then a few years after the triple aim came out, there was another landmark paper that said, wait a minute, we forgot an aim. And that aim is all about improving the work life and well-being of healthcare providers. Even before the pandemic hit, we had an epidemic of clinician burnout, depression, and suicide. So in 2017, the National Academy of Medicine launched the Action Collaborative on Clinician Well-being and Resiliency to come up with the evidence-based solutions to remedy this terrible issue. Because we know when our clinicians are burnt out and depressed, they make more medical errors. And preventable medical errors are now the third leading cause of death in America. Well, I was blessed to be one of 60 leaders who got appointed to this Action Collaborative. If you are not plugged into it and you are a clinician, please just Google the National Academy of Medicine Action Collaborative on Clinician Well-being and Resilience. We created a knowledge hub with a lot of evidence-based solutions. So in 2003, after a summit the Institute of Medicine, now called the National Academy of Medicine, said all healthcare professionals will be educated to deliver patient-centric care. As members of an interprofessional team emphasizing evidence-based practice and quality improvement approaches, I want to emphasize about QI. So much quality improvement nowadays in a lot of hospitals throughout the country is not evidence-based quality improvement. We must push evidence-based quality improvement, not just getting a bunch of leaders together, talking about the problems, throwing a bunch of spaghetti up on the wall to see what sticks. We've got to use best evidence and rapidly translate it into our systems to reach that quadruple aim. The IOM Roundtable also said, they set a goal by 2020, 90% of healthcare decisions will be evidence-based by 2020. I would love to be able to tell you we're there. We have so much opportunity in front of us. In 2013, this paper was published. This group studied EBP practices of 6 groups of professionals. And what they found was that so little of the professions were consistently implementing evidence-based practice. Well, we have joked around for years as a result of this paper that it takes 17 years to translate findings from research in the clinical practice to improve care. But I'll be honest with you, I say 17 years if you're blessed. Most researchers never get a chance to say, my work, the evidence-based interventions that I've developed over my whole career are actually being used in the real world to improve outcomes. So the gap between what we know and what we do is lethal. When should we change what we're doing? It's when we know there is good quality evidence out there to support the practice change. Implementation science needs to have more funding because it systematically closes that research practice gap by identifying and addressing the barriers that slow the uptake of research into practice, as well as identifies the facilitators. I would love to say our United States healthcare system has the best outcomes in the world. Sadly, although we spend more money on healthcare than any Western world country, we rank about 37th in population health outcomes. A big reason is we don't more quickly translate what we know works based on best evidence into practice. This is just one exemplar of this big problem. We are the worst Western world country to deliver a baby in. 700 women die every year from childbirth in the United States. A lot of those women die because clinicians aren't implementing the best evidence-based guidelines for complications such as hemorrhage and high blood pressure. On the other hand, we often see things take off and scale without hardly any evidence. I was appalled to be watching a national TV show, I believe it was 2020, a couple years ago. They featured the surgeon that was sewing a plastic little patch to the anterior of the tongue of women for $2,000 a pop to lose weight. When the reporter interviewed this doc, she said, "What evidence do you have behind the tongue patch?" And the reply was, "I've got anecdotal evidence that it's working." And the reporter said, "Well, how does it work?" And this was the answer: "It creates so much pain to swallow anything but liquid. It's like a behavioral modification device." I would call that the definition of insanity. We know so many barriers continue to exist that people aren't implementing evidence-based practice. And this is one big one, because we've always done it that way. So we have buttons here at our Fold Institute, pass them out like crazy. We held our second biennial summit on promoting well-being in healthcare providers this past October. I had the US Surgeon General give the keynote, and he said, this is one of the biggest problems we have in translation. So I sent him, and he welcomed me, sending him a bunch of these buttons to distribute to his people. Through implementation science, we have learned there are key organizational contextual factors that speed the translation of research into practice. Culture, that is such a big factor. Culture eats strategy for breakfast, lunch, and dinner. And it takes time to change culture. Leadership is so critical. Communication and networks, resources, champions, evaluation, monitoring, and feedback. But other major factors that influence adoption of evidence-based interventions or guidelines or practices include characteristics of the evidence-based intervention or practice, strength of the evidence behind it, ease of administration, cost, characteristics of the clinician. Do they understand this evidence-based intervention? Do they believe in it? Because we know cognitive beliefs greatly influence what people do. And then do they have confidence, efficacy to implement it? The process through which the change is implemented also heavily influences adoption. I was on the Hill right before the pandemic struck, and I said to a legislator, please help us more rapidly speed what we know works through research, cover it with funding. And that legislator said to me, well, Bern, don't ask for more funding. Tell me what we can do with the funding we have. And I said, I've got a solution. Defund all the things that we fund now that are not evidence-based and use that money, reallocate it to the things we know work. Well, I started beating the drum for evidence-based practice back in the 90s. My colleague and I started working on a system-wide model to speed the translation of research into practice. That model we call ARC. We have conducted now about 8 studies to support the relationships in this ARC model. The first thing we do when we go into a system, we measure organizational culture and readiness for evidence-based practice. So we identify strengths and barriers, and then we can formalize a plan to overcome those barriers. But the key piece in our model that is so effective is the development of a critical mass of evidence-based practice mentors to work hand in hand with clinicians to consistently implement evidence-based practice at the bedside. What we've learned through our studies is when you have a critical mass of these mentors in place, clinicians' knowledge, beliefs about evidence-based practice go up, they implement it more, and we see all of these wonderful so what outcomes, increases in job satisfaction, decreased turnover rates, a higher quality of care, and improved patient outcomes. Well, I have been banging the drum for nearly 2 decades on evidence-based practice. And I told my team, we still don't have competencies in evidence-based practice for practicing nurses and advanced practice nurses. So through research, we developed 24 evidence-based practice competencies, 13 for bedside nurses, and additional 11 for advanced practice nurses. After we developed these competencies, we wanted to do a national study because we wanted to see, did the nurses report themselves as competent in these competencies? We were pretty disheartened with the results. When you combined it, all of these 2,000 nurses together from 19 hospitals and health systems across the country, when they were combined as one sample, the nurses reported not meeting even one are these competencies? I kept going back to my statistician saying, can you run the data again? This can't be. She ran it again with the same results. So then I said, would you separate the groups, the master's prepared people from the bachelor's associate degree people? As you can see on the slide, even when separated, the master's prepared people reported they were competent in just one of the competencies, and that's questioning clinical practices for quality improvement. So again, if you look at the goal, 90% of our clinicians will be evidence-based by 2020. Sadly, we've got a long way to go. Well, we took all the variables and through a structural equation model process, figured out what are the key drivers of evidence-based practice competency and implementation. What we found, it's organizational culture and having mentors to work with these bedside clinicians. That drove everything else in the model. So one other factor that you typically don't see in the literature as important in this translation scalability work is what I've dubbed so what outcomes. So what outcomes are key outcomes that really matter to the healthcare system right now. We still, through our research, our evidence-based projects, still measure way too many warm and fuzzy outcomes. We need to make sure we're measuring things that are right now super important to the healthcare system. Whether we like it or not, we live in a cost-driven healthcare system. We need to be measuring cost more in our studies, core performance metrics, ND, NQI metrics, because the C-suites who are responsible for making change in our systems, they really want to see what's the return on investment if we make this evidence-based change. I had to learn about the so what outcomes the hard way. I was doing research for about 18, 20 years on my COPE program for parents of critically ill children and parents of preterm babies. After about 8 studies, all with the same findings, COPE decreased parent depression, stress, post-traumatic stress disorder, and improved preemie outcomes through 3 years of age. But after all of this research, not one NICU, not one hospital in this country was implementing COPE with parents until this R01 multi-site trial that I was funded to conduct that showed, in addition to all of those other fantastic outcomes, we got length of stay differences. Preemies of parents who got COPE went home 4 days sooner, 8 days sooner for babies under 32 weeks. Well, when I published this study and a cost effectiveness analysis that showed if every parent of a preemie COPE, we could save the US healthcare system between $2.5 and $5 billion a year. When I published those findings, my phone rang off the hook. Bern, how do we get trained on this program? How much does it cost? Would you come and teach our staff how to implement it? I was not prepared for that as a researcher. I never was mentored by anybody to say, if you're successful at developing a great evidence-based intervention, how are you going to translate it? How are you going to scale it? I had to teach all of that myself. I had to get a lawyer to advise me. How do I start a company? What kind of company should that be? I had to get somebody to help me with a business plan. But without measuring this so what outcome, COPE would still not be used in hospitals throughout our country and world. So in a parallel research track, I also felt I wanted to develop a cognitive behavior therapy-based intervention that could be delivered by non-psychiatric providers, because so many children, teens still do not get treated when they're suffering from mental health issues. We have a mental health epidemic that exists in our nation. Now with the pandemic, we have a mental health pandemic inside of the COVID-19 pandemic. Suicide being the second leading cause of death in 10 to 34-year-olds. The MMW report that came out in August, a study was done and it found 25% of 18 to 24-year-olds have considered suicide since the pandemic started. We will see an uptick in suicide as a result of the pandemic. And in addition to all the mental health problems being triggered by COVID, people are coping in unhealthy ways. We are seeing increases in alcohol, drug use, unhealthy eating, and decreases in physical activity. Let's think about those statistics further. Right now, the CDC predicts 1 out of 3 people will have diabetes by 2050. But as a result of people using unhealthy behaviors to cope with COVID, we're going to see 3, 5, 7 years down the road, so many adverse outcomes, increases in high blood pressure, diabetes. We have got to get people moving more, sitting less, and engaging in stress reduction behaviors that can help them. So 25 years ago, I was consulting for a child and adolescent inpatient psychiatric unit, and I was astounded at the fact that even though we knew cognitive behavior therapy is gold standard evidence-based treatment for clinical depression and anxiety. These kids weren't getting it. They got a lot of psychotropic meds, but nobody was giving them these cognitive behavioral skills, which are so important because we know the root causes of so much depression and anxiety are negative patterns of thinking, automatic cognitive distortions that we don't even realize we have anymore. That's when I started to develop and test my CBT-based intervention with these teens. I developed it first as a 15-session weekly program that had 7 sessions of cognitive behavioral skills building and 8 sessions of nutrition and physical activity. Well, CBT guides COPE. I basically just manualized CBT. In CBT, we teach how we think affects how we feel, how we behave. And I really hypothesized that this intervention would improve knowledge, cognitive beliefs that these kids could engage in healthy lifestyle behaviors and regulate their emotions. And I predicted those beliefs and that knowledge would result in all these improvements in outcome measures. This program, just like CBT, teaches the ABCs, monitoring for activating stressful events, then stopping and catching and checking your thoughts. What was just going through my mind? Is it helpful? Is it true? Chances are it's not. So then we have to teach people how to turn those negative patterns around to positive. Mindfulness integrated CBT shows less relapse. So I made sure I integrated mindfulness skills through the program. Goal setting is also self-monitoring, important skills in CBT. And after every session, the teens would get skills building activities, because in order to change thinking and behaving, you've got to put it into daily practice. It typically takes 30 to 60 days for a behavior change to stick or thought change to stick. So the first 7 sessions, again, focus on CBT content, followed by physical activity and healthy eating. The last session pulls all of this together. Well, I went on to get funded by NIH, NINR to test this program in 11 schools, half of them randomly assigned to get COPE delivered by teachers. Because again, I really believed if I could create a program that could be delivered by teachers, nurse practitioners, pediatricians, we could really get needed evidence-based help to so many children and teens who are suffering from depression and anxiety. So this clinical trial showed students who got COPE were more physically active. Students who started the program extremely depressed were no longer depressed after the program. They used less alcohol. But my so what outcome factor in this study was academic competence and grade performance, because I knew if schools were going to adapt this or adopt it all throughout the country, this was going to be a big so what outcome, why they were going to choose to implement it in their settings. The other thing we showed, which we were thrilled about, because the program increased physical activity habits, these teens had less change in BMI, even 12 months after the intervention ended. Not one teen crossed over from being overweight to obese in the COPE group. Depression was still not a factor for the teens who started severely depressed 12 months later. And we had hundreds of pages of positive feedback from the teens in terms of how this program helped them. Well, shortly after I published the findings from this trial, I got a call from the National Cancer Institute, and they said, Bern, we want to consider your program for our research-tested intervention programs. We need to have all your materials. It's going to go through rigorous evaluation. I sent them everything, and about a year later, COPE was designated a research-tested intervention program for obesity control by the National Cancer Institute. They also rated it the highest level for dissemination capability. So after that trial, or alongside of that trial, because we were seeing so many great effects on depression and anxiety, I pulled out just the 7 weekly CBT sessions, and we begin to test that with children, teens, and college students who were suffering with depression and anxiety. We now have 22 studies with great outcomes, increases in self-esteem, decreases in anxiety, depressive symptoms, and suicidal ideation, and increases in healthy lifestyle behaviors and academic performance. I just published last year another cost analysis that showed for every hospitalization for depression that is prevented, we save our healthcare system over $14,000. As a result of me focusing on so what outcomes, this program is being used in all 50 states and 5 countries. It's being delivered by primary care providers who are getting reimbursed to deliver it at the 99214 CPT code. I would have died a very unhappy camper if I invested 35 years of my life in developing these evidence-based interventions and nobody was using them. But thank heaven they've scaled and they're helping. We've got to shift our paradigm from crisis intervention and sick care to wellness. We've got to build resiliency, cognitive behavioral skills, and protective factors in our children and in ourselves. We would never send divers into a deep ocean without an oxygen tank. We can't keep seeing this as optional. The building of mental resiliency, coping, cognitive, behavioral skills, because our students will be much more successful in academics and in life if we give this to them as prevention. My dream is every child, teen, and college student in the world learns these cognitive behavioral skills, and a world that's free from mental health disorders and chronic disease. Well, a few years ago, we also received funding to test an adapted version of COPE with minority pregnant women who are depressed or anxious. We have enrolled about 260 women in this trial. We are studying them through birth of the baby and 6 months later. Well, any dream that we have is worth working at, is worth persisting through all the character builders. It took me 10 years of pitching a dream for a National Institute for Evidence-Based Practice to the Helene Fould Health Trust. 10 years, year after year, I flew to New York City to pitch this dream. After 10 years, the trustee finally said, I think I now get it, why this is so important. How much do you need to launch this institute? Because I'm a competitive Buckeye, their largest gift ever to that point was $6 million. So I said $6.5 million. The trustee said, I think we can do it. Come back, present this to the administrative team. I did that. And in 2017, we received $6.5 million. So this institute will be permanently there in perpetuity to help people translate research into practice. So I'm just going to finish with some tips for wellness for all of you. Cardiovascular disease is still the #1 killer in America. But if we look at all causes of death and disease in the United States, it's really our behaviors that are the #1 killer. All of these, plus beware of your chair. Research shows if we sit even 3 hours a day, it increases our cardiac risk by 30%. Prolonged sitting also drains our energy. So if you want to improve your cardiac health, stand more, move more, and sit less. I wish I could share facts with people and it would motivate them to make a behavior change. But sadly, most people don't change unless crisis happens or their emotions are raised. So I want you to watch this film while you think about what you're doing for your own self-care and your healthy lifestyle behaviors right now. And if you keep doing or not doing what you're doing, what will the last 10 years of your life look like?
What will your last 10 years look like? Will you be quick enough for a game of tag with your grandchild? Strong enough to embrace every moment? Will you grow old with vitality? Or get old with disease? It's time to decide.
That's a very powerful clip. We need to facilitate emotion in people to really facilitate behavior change. You heard my story. I have terrible cardiovascular genes, but we know from research more than our genes, our social circumstances, our healthcare. It's our behavioral patterns that are the biggest contributor to premature death. This is a real fitness facility in the state of California. You have a choice. Walk the stairs, take the escalator to go work out. A group of psychologists studied how many people during the course of a day, during the week, would take the stairs, not the escalator. They're finding 2 people only a day. So when we're faced with choices, let's choose the healthier ones. And if I had to give you an evidence-based recipe, how to cut your risk of chronic disease by these substantial numbers, I would tell you just do this simple recipe. Physical activity, 30 minutes, 5 days a week. People say, you're crazy, Bern. I don't have that time. I say, sure you do. Cut at least 3 meetings down throughout the course of your day from 60 minutes to 50 minutes. So you have 10 minutes to walk up and down some stairs, to do some jumping jacks. Just move more, sit less. 5 fruits and veggies a day. Don't smoke. If you don't drink alcohol now, don't start. But if you do, limit it to 1 drink a day. Everybody loves that last one. And then they ask me, Bern, how big can that drink be? And I tell them, not the size of the alcoholic beverages in Vegas. Sadly, though, only 6% of our population engages in these 5 leading health behaviors. What happens if we could get it just to 20%? We would get healthcare spending down so much and improve the lives of so many people. So I'm going to ask you to set a New Year's resolution today. Don't wait till next January 1. Just take one of those behaviors I pointed out and make a little improvement. Write it down, your goal. Put it where you can see it every day. And if you fall off the wagon one day, it's okay. Get back on the next day and keep going. We cannot continue to pour from an empty cup. If we don't take time for good self-care today, we're gonna have to make time for chronic disease later. These are my main reasons who keep me motivated every day to engage in healthy behaviors, because I didn't have a mom to see me graduate from high school, college, go on to have this beautiful family. I want to be around. They want me to be around. So who's going to be your motivators just to get a little bit better at your own self-care? Well, we're going to be coming out of the pandemic. There's going to be rainbows that are going to follow rain. Right now, more than ever, we need to keep dreaming, discovering, translating evidence into practice, delivering evidence-based interventions to improve population health. And if I couldn't motivate you enough, this little girl is going to do it.
Do it! Just do it! Don't let your dreams be dreams. Yesterday you said tomorrow. So just do it! Make your dreams come true. Just do it! Some people dream of success, and you're going to wake up and we're going to work hard at it. Nothing is impossible. You should get to a point where anyone else will quit. And you're not going to stop there. No, what are you waiting for? Just do it. Just do it. Yes, you can. Just do it.
Love that. Lots of inspiration for sure. Steve, I see I went a couple minutes over today, but I'm happy to hang around for anybody who might have questions.
Well, thank you so much for your amazing and inspirational chat. You shared so many great ideas. I know some folks are having to leave, but for those that are here, there was one question that came through that you might be able to answer quickly, and that was regarding the goal of having evidence-based practices used by 2020. The question is there a report available that's talking about the progress on that, or is there one coming, and could people see that?
Yeah, we actually in the Fold Institute are working on a report now because that hasn't been updated and we still use some outdated data. So that's what we're working on now. Out of the Fold Institute, I can let you guys know when that comes out.
Great, we'd be able to share that through our social media and to let our campus and our community know about that. Well, again, thank you for your great presentation. And we hope that everybody's been able to enjoy that. If you're still with us, we invite you to join us tomorrow, in fact, for our monthly conversation with one of our scholars of the month, Lasana Kasembe, who will be at noon on Friday online talking about the living tradition, pedagogy, arts learning, and liberatory praxis. And we'll be doing this once a month, so we hope that you'll be able to join us. You can also always follow us on Facebook, and you can also follow us on Twitter. And please check out our website at any time to get more information. And we look forward to bringing continued opportunities like this to engage and think and move forward with taking evidence and turning it into practices that help make the world a better place. So thank you so much, Dean Melnyk. We look forward to having you back again. Thank you all for joining.
Bye, everybody. Take care. Stay well.